All right, good afternoon, everyone. My name is Jennifer. I'm a clinical research fellow at Oxford University, and today I will be talking about hypercoagulability in TB and post-TB. So this is an outline about what I'll cover today, and I'll really cover what we know and also what we don't know about the changes in coagulation, both during acute TB as well as after the successful treatment of TB. So let's start with some questions. Does active TB cause hypercoagulability? How does active TB cause hypercoagulability? Does hypercoagulability persist in post-TB? And what would the implications of this be, given that there are approximately 155 million TB survivors? So this diagram shows the time course of acute TB at the top, where the patient gets infected with TB, then some weeks to months afterwards they develop active symptomatic TB disease, present to hospital and get diagnosed with their TB. They then get successfully treated for their disease and move into the post-TB phase. And the bottom two figures in red is really what we're going to be talking about today. And these reflect the hypercoagulable state that develops and peaks during acute TB disease, but may continue for a variable period after TB. So over the past few years, TB has become increasingly recognized as a risk factor for venous thrombosis, but it is still likely under-recognized in high prevalence settings. A recent systematic review and meta-analysis found that the prevalence of VTE in patients with active TB was 3.5%, where the prevalence of pulmonary embolism was 5.8%, and the prevalence of DVT was 1.3%. And this corresponded to patients with active TB having a 2.9-fold higher risk for VTE. So VTE may be either the presenting feature or a complication of established TB. In high prevalence areas, TB is one of the most significant risk factors for VTE. And Moodley et al. Showed that in hospitalized patients with VTE, 39% had TB. Therefore, it is important to consider TB in patients presenting with a seemingly unprovoked DVT in high prevalence areas. Multiple sites of VTE are also reported, and this highlights the systemic hypercoagulable state associated with active TB. Approximately 6% of cases with pulmonary TB will have a pulmonary embolus, and this is much more common than was previously recognized. Overlapping presentations of both diseases may cause misdiagnoses and worsened acute presentations. So the pathophysiology of TB-associated VTE is complex and multifactorial, with systemic inflammation, endothelial dysfunction, platelet activation, and suppressed fibrinolysis all contributing to a systemic hypercoagulable state. These cellular and metabolic changes are often coupled with increase in other risk factors for thromboembolic disease among TB patients, such as acute illness causing poor mobility and/or hypoxia, HIV, rifampicin-based therapy, and together the risk of VTE may be profound. So I'm just going to briefly touch on three of these mechanisms for hypercoagulability in TB. First, TB-induced inflammation releases pro-inflammatory cytokines, which, while crucial for fighting the infection, also has a pro-thrombotic effect. Second, TB damages the endothelium, disrupting its anticoagulant properties and promoting platelet adhesion, aggregation, and coagulation. And lastly, the interaction between TB and immune cells, specifically macrophages and neutrophils, has hypercoagulable effects. In this paper, the authors show how monocyte-derived macrophages upregulate tissue factor expression in the presence of MTB. This upregulation appears to be more significant than stimulation with LPS, a well-known stimulus and component of gram-negative bacteria. And it was more related to the presence of MTB than the inflammatory cytokine induction in monocyte-derived macrophages. So VTE developing in the setting of TB may affect all aspects of the clinical course, from diagnosis to admission and treatment to patient outcomes. Both treatment and prognosis are more complicated in patients with TB and VTE. Managing anticoagulation in TB patients with VTE presents unique challenges, particularly due to drug-drug interactions between vitamin K antagonists and anti-TB medications such as rifampicin. Direct oral anticoagulants present a promising alternative. However, despite theoretical benefits, there's currently a lack of published data assessing the safety and efficacy of DOACs in combination with anti-TB treatment. In-hospital mortality in patients with both active TB and VTE has been shown to be higher than mortality in patients with only TB or only VTE. An important aspect of TB care, therefore, should be to recognize those at high risk for VTE. However, traditional risk stratification models have been found to perform poorly for the identification of those with TB at risk for VTE. Therefore, establishing the risk factors for VTE in TB is really important, and some of these proposed risk factors are listed on this slide. So briefly, acute TB is associated with VTE, which mechanistically occurs via multiple pathways. VTE significantly impacts the clinical course in TB patients, and we need to find out more about the risk factors associated with VTE in order to better identify high-risk patients. And this brings us to our next question. Does the risk of VTE disappear after the successful treatment of TB? And here, if the answer is no, two possible models exist. In Model A, hypercoagulability returns to baseline, but only sometime after the successful treatment of TB. And in Model B, hypercoagulability reduces significantly, but may never return to baseline. So what evidence is there that hypercoagulability may persist after successful treatment? Well, the short answer is that there is a notable gap in the post-TB literature about this. There are, however, three arguments that support this, and these are: one, that the incidence of VTE is higher in studies assessing patients with TB for longer periods after TB diagnosis; two, deductions from other chronic and post-infectious diseases suggest that this is possible; and three, there are plausible mechanistic pathways for the development of post-TB VTE. So starting off with what we know about coagulopathy and other post-infectious conditions, and the first one that would come to mind for most people here would be post-COVID syndromes, where an increased risk of thromboembolic disease is observed. Although the underlying mechanisms are multiple and complex, two important mechanisms of post-COVID hypercoagulability is the persistence of thromboinflammation even after resolution of disease and ongoing endotheliopathy. Changes in coagulation have also been implicated in long COVID-19, where so-called microclots made of amyloid and fibrinogen have been postulated to occur. These post-infective changes are also seen in other infections, with typhoidal and non-typhoidal salmonella being the prototypical examples. In mice infected with Salmonella typhimuriae, thrombi form in the liver from 7 days after infection and may persist for several weeks. In humans, a large study in Taiwan showed that people previously diagnosed with non-typhoidal salmonella had a nearly twofold higher risk of new onset DVT and PE. This is the same figure I showed earlier, and the real question is which of these mechanisms may persist into post-TB? And I've indicated with the question marks those that are likely to persist. For example, although systemic inflammation should resolve after acute TB, this study found that patients with tuberculosis had persistent molecular perturbation, which did not significantly change over the 6 months of anti-TB treatment. And around 90% of patients remained molecularly perturbed even after 6 months of treatment. This suggests that MTB infection may have durable, long-lasting systemic effects on inflammatory responses in TB patients. Clinically, in 30 to 50% of cases of VTE, no cause is identified. And this begs the question, could some of these cases be associated with previous TB? In addition, post-TB hypercoagulability may present as chronic thromboembolic pulmonary hypertension, either as a long-term complication of acute PE or in patients without a prior history of PE but with a prothrombotic tendency. So to conclude, does active TB cause hypercoagulability? Yes. How does active TB cause hypercoagulability? Well, it's multifactorial. Inflammation and immune cells are key role players. Does hypercoagulability persist in post-TB? It's probable and even highly likely, but we need more evidence. And I'll leave you with the last question. What would it mean if hypercoagulability never returns to baseline after TB, given that there are approximately 155 million TB survivors? Thanks.
Great. I think you've got time for one question. Intan.
Very nice. So I was wondering, we often see that pulmonary TB patients have thrombocytosis. So do you know any data, or do you think that thrombocytosis can predict the risk of developing VTE? And should we also then measure CBC at the end of TB treatment, for instance?
Yes, I think there is some data saying that definitely platelets are involved, both sort of the activation of platelets and also, as you said, increased number. So yes, I think that would be important to measure.